So I'm excited about this because we're going to break down a case study and we're going to talk about the progression. We're going to talk about what I'm thinking clinically and what you should be thinking and what your expectations should be and the application of rehab. And then Dr. Lev is going to take that a little bit more in depth to explain why it's important and how it's important. And even more importantly, how easy it is to apply. I'm excited. I'll tell you why I'm excited. And Lev and I were talking about this is that, for a long time, acupuncturists, have been kind of looking over their shoulder in some states because of other practitioners that do what? That do acupuncture or dry needling. If you look at the stats, 10 to 20% of non-TCM acupuncturists, so we're talking medical doctors, chiropractors, physical therapists, 10 to 20% practice a form of acupuncture or needling, Only 10 to 20%. But the best kept secret here is, ladies and gentlemen, is that 100% of acupuncturists, TCM acupuncturists, 100% of acupuncturists can provide a modicum of rehab exercises. So we shouldn't be worried about them. They should be worried about us. That's the secret here that everyone's not getting, is they should be look out. Once acupuncturists put it all together and do assessment and treatment with electroacupuncture, or even non-electroacupuncture, manual work, and we prescribe rehabilitation know-how, they should be worried about us, not the other way around. So there's a lot of reason to be optimistic. Excuse me one second. So here's the patient presentation. Follow the red dot. So this patient came to me, 34-year-old male, with low back pain, gluteus maximus pain, with radiation over the right, down the right back of the hamstring, to the knee, occasionally past the knee. So back pain with pain going down the leg to the knee, but occasionally past the knee. But he rates the pain 6 out of 10, and it began 2 weeks ago after painting. What makes it worse is when the patient experiences pain when he bends forward from a standing position. Walking makes it worse. Sitting and lifting objects 10 pounds or more will cause the low back pain. Local pain with coughing and sneezing, and patient is able to sleep and lay down without pain. And massage therapy, they had massage therapy, but it aggravated the condition a little bit, just what the patient reported. But what makes it better is patient took a Proxen over the counter, 220 milligrams twice per day, and moist heat applied over the right gluteus maximus was helpful. Imaging. So this patient had an MRI taken in 2018 that showed moderate disc bulging at L4, L5, and S1. Patient history observations, a focus history, and review of the intake form revealed. Remove the intake form. Remember, you got to look at the intake form. That's another very important part. No inflammatory arthritis, no diabetes, no chronic systemic disease or characteristics of chronic systemic disease. A normal functioning nervous system. All right, we covered that, right? Now, I'm going to share with you, we're going to go through those slides again, and I'm going to share with you what I'm thinking in every step and what you should be, how you should be approaching the clinical realm of the patient treatment. So in the patient presentation, 34-year-old male has low back pain and glute pain down the knee, down the back of the leg to the knee, occasionally going past. So this is an observation. The thing what happens most of all is practitioners try to think, what is it? Oh, is it a sciatic nerve? Oh, it's SI joint. It's this. It does not matter. Don't focus on that. Don't try to draw a conclusion. Remember, when you're going through the XDOR history taking or any history taking, ask focused questions. And it's listed there, how I teach it online or in the course. That's why there's that list of questions to get a better understanding. What makes it worse? Now, what's unique about what makes it worse is that, all right, pain, bending forward from a standing position, walking, sitting, lifting objects 10 pounds or more, less than 10 pounds, they were fine. Like if they're, lifting a pot of coffee or something like that. Local pain with coughing, sneezing. Patient is able to sleep and lay down without pain. And they had a treatment, they had some massage and it wasn't help. So here's a good thing. Not everything makes it worse. That's good news. Why is that good news? Because in chronic systemic patients, everything makes it worse, right? That's a characteristic of chronic systemic. And if you're not sure what chronic systemic is, if you're joining us and you're like, well, what are you talking about? It's good that you're not sure, because this is the ground floor. And as you see, as we progress, if you start to get an understanding as what chronic systemic is, and you really see that there is a dichotomy of injuries, that you can go one way or the other, mechanical or chronic systemic, most of the time, almost all of the time, then if you understand which way it goes, you can better treat it and get better results. The second thing is that what I got from this is core inhibition. All right, there's definitely core inhibition here, and research shows that any type of low back pain, you will have core inhibition. Research shows that QL, transverse abdominis, internal external oblique are all inhibited with any low back pain patients. So when you get pain going down the leg, you're thinking, okay, there's core inhibition, but there's potential nerve root tension or SI joint dysfunction. Now, XDOR helps zero in. Is it SI joint dysfunction? Is it potentially space occupying lesion? XDOR, we added something a little bit different, and I demonstrated in the last course in Hamilton in November with respect to a different interpretation of the active straight leg raise. We're going to touch upon it here. We'll talk about it more on locals and, of course, in the live courses. What makes it better? What am I thinking when I see that naproxen and moist heat help? Well, the fact that the patient gets relief from meds and heat tells me that it's likely not chronic systemic, because typically chronic systemic, nothing helps. Imaging. All right, these bulges at L4, L5S1 3 years ago. What does this mean? It means nothing by itself. Do not let imaging, past or present, influence you before you do your physical exam or your XDOR exam. Patients bring in, this much of imaging and MRIs. Irrelevant. Why? Because you haven't seen them yet. All right. There's a quote, one of my favorite movies, the King's Speech, where the Queen goes to see the speech pathologist and says to the speech pathologist, my husband, the king, has seen everybody. Nobody can help him. And he says, he hasn't seen me yet. That's how you should approach things. All right. With confidence. Don't look, sure, have them bring in the X-ray and the MRI results, but don't hang your hat on them. In general, 1/3 of all people over 30 years old have disc bulges or disc herniations and don't have low back pain. So the fact that there's disc bulges here, it's irrelevant, because at one time they had those bulges but didn't have back pain. So in the patient history observations, again, no inflammatory arthritis, no diabetes, no chronic systemic disease, a normal functioning nervous system. So this is key, all right? This is key. And I reiterate this. And if you're not unsure what this is, make sure you get clear on this, because it will make you a better practitioner. If you cannot recognize chronic systemic characteristics during the history, you will fail as a practitioner. You will fail with that patient, because it's the number one reason why practitioners do not get constant positive clinical results. It means that if you have someone who comes in with shoulder pain and you treat that as a mechanical problem, but they clearly have chronic systemic issues, diabetes, psychogenic issues, things like that, you're going to get it wrong. In fact, you're going to make it even worse. And they're going to take that experience and say, I went to Dr. So-and-so, acupuncturist so-and-so, and they made it worse and it didn't help at all. It's as simple as recognition. If we get it right from the beginning, it'll dramatically improve your results by minimum 50%. Cito, come on. Allora, sorry, I'm speaking Italian. Assessment. So what I do for the assessment, I used XDOR. And so X-Door, of course, is with mechanical presentations only. And it only takes about 60 seconds when you're familiar with it. Quick, easy, applicable. The inhibitions I found, the muscles that were shut off, that were demonstrating as weak were right gluteus maximus, right transverse abdominis, internal and external obliques. Part of the X-Door is the SLR, the straight leg raise, which was positive for pain locally in the low back at 40 degrees. And then the active SLR, which is a modified sacroiliac joint orthopedic test, was positive on the right. Positive in that this test, when it's explained, when it's positive, is positive for inhibited transverse abdominis, which is what? A core stabilizer. When this stabilizer, the transverse abdominis, cannot contract, what happens is the multifidus can't contract either. So we're going to have a deconditioning of the of the tissues. So what is your goal? Cross. What is your goal? All right, because I think this is a question to ask yourself. We've gone through this. We know how I'm thinking, how you should adjust your clinical thinking to give you an advantage. What should your expectations be? Like I said, officially, and how I teach it is 50% improvement should occur after the first or second visit. In a case like this, that's a mechanical problem. So after the first or second visit, we should have 50% improvement. But in reality, my goal and what I expect to see is a 75% improvement after the first visit. And that's after a focused history, X-Door exam, and application of the treatment. Because if you get it right, and it's not difficult to get it right, if it's a mechanical problem, you find what isn't working, you correct it, you're going to get outstanding changes. And that's the practice builder. That sets everything up. That sets the rehabilitation up. That sets future visits up. That is the setup. Things you need to be able to do. So things you need to be able to do as a practitioner. One, correct mechanical MSK issues. And two, make significant change in the chronic systemic MSK pain. So if it's a mechanical problem, you need to be able to do that effectively. If it's chronic systemic, you need to be able to manage that, the autonomic nervous system, effectively. I've added the transitions myself. What if I can't? You know, if you ask yourself, well, what if I can't do those things? Or what if I don't? What if I do those things and I still don't get good results? So if that's the case, the problem is one of two things. It's either you or it's them being the patient. So what do you mean by you? So the practitioner, it's because either you didn't take a good enough history, you didn't ask the right questions, you didn't focus on the right things, you didn't do a proper MSK assessment, whether it has to be functional, whether it's X-Door or not, it's irrelevant. It has to be a functional MSK assessment. Your treatment was not specific enough, or it was just plain incorrect, and or you're not using enough manual work. You didn't use your hands enough. You didn't use enough gua sha. You weren't specific enough with that. Or it could be them. If it's them, it could be because they're faking it, right? They're malingering because they want to settle for an insurance settlement. How many times have you had that where they've had a slip and fall, an auto accident? They're not going to get better. And that's dangerous. I'll tell you why, because these people that are malingering, they're malingering for long enough, their brain starts to believe it. They become chronic systemic. Or the patient has chronic systemic and or psychogenic issues that cause an unpredictable autonomic nervous system that cannot easily be contained. This, when it's them, this is why it's them. You could be doing everything right. We cannot neuromodulate the autonomic nervous system because small changes in the mind, the body, and the external environment cause large changes in the autonomic nervous system pain processing system. And that's just something that we have to work with, we have to deal with. So sometimes it's not you and it's them, but it's, we do our best in that condition. So this is it. This breaks it down. So what treatment did I do? So for treatment one, After the assessment, I found what isn't working. We saw the transverse abdominis was inhibited, the gluteus maximus on the right. I corrected it using motor points and the pointer plus. That takes seconds to do. We're talking 30 seconds, 40 seconds. Then I did a 2-needle technique. And I understand you may not be familiar with these techniques, but this is, again, entry level, a ground floor. For those of you who are familiar with it, this is a great review, and it's great to see it all together with the rehab. 2-needle technique to the adhesions, to the trophic changes, the tight bands in the gluteus maximus. And I ran that for 12 minutes at 2 hertz. Then I did the soft tissue release to the sacrotuberous ligament, the dorsal sacral ligament, which is along the posterior fascial line to include the gluteus maximus. You see any of the webinars where I talk about vectoral lines of tension, the posterior fascial line along the back of the hamstring, right up into the sacroiliac joint. And then I give them homework. I gave them nerve flossing to the sciatic nerve region. And what nerve flossing is, it flosses the nerve. It helps separate the nerve from the surrounding tissue. Just like when you're flossing your teeth, and you reach a point where you get it stuck kind of in a tooth, and then you kind of rejig it and you loop it through. That's what nerve flossing is on a simplified level. We teach the patient how to loop it through, how to release neural tension and improve range of motion. Visit number 2. 2 days later, the patient originally rated their pain 6 out of 10, is now 3 out of 10. Leg pain was only proximal, in the proximal region of the hamstring. So it was well above the knee. It was centralized. It's called centralization of pain. Patient reports they can sit longer. They can walk longer distances. So benchmarks, positive improvements. I performed a 2-needle technique, adhesions in the gluteus maximus, again, 2 hertz for 12 minutes, and the same soft tissue work. And this time I advised them to continue the nerve flossing technique, and I gave them core stabilizing exercises. After the second treatment, so at the third treatment, this is what they reported. I reassessed bilaterally. Their straight leg raise was 65 degrees without low back pain. Remember the first time it was on the right, it was positive at 40 degrees with back pain. They're no longer taking medication. Their bending forward is, to quote them, 90% better. The pain was rated 1 to 2 out of 10. The active SLR was negative, so it was equal on both sides, and motor inhibitions remain corrected. Home exercise prescription. So how do we apply it? And how... Come? Tito, per piacere. My apologies. How do you decide on home exercise prescription? So this is what it needs to be. It needs to be something that's easy to perform anywhere, whether they're at work, whether they're at home, whether they're in the backyard. And it's got to be something simplified that they can actually achieve. The movements need to extend the effects of treatment. So if treatment helps improve range of motion and improve strength, then those exercises need to improve range of motion and improve strength and maintain strength. Exercises that motivate the patients to do them. So you want exercises where the patient sees the results and they want to do it more. Exercises that can be done in shorter increments, multiple times throughout the day. So a little bit over the course of the day is really beneficial, especially for someone who isn't used to exercise. Majority of the people are sedentary, and so we need to baby steps. Exercises that are easy to explain to the patient, and explaining how they work is important, because if they understand how it works better, because when they're doing it, they'll understand what they're doing and why they're doing it. So this leads me to Dr. Lev, why our home exercise is needed. And he has set up a small PowerPoint that he will go through, and then we will discuss